Well, good afternoon, everyone, and thank you for joining us. This independent scientific advocacy group webinar is on the subject of the origin of SARS-CoV-2 infections on the island of Ireland. The Independent Scientific Advocacy Group is a volunteer group of scientists and other academics who aim to provide an evidence base for pursuing effective strategies for dealing with COVID-19 in Ireland. And we want to see ideally zero COVID elimination orientated strategy so that we can control this virus and get back to normal social and economic activity as much as possible. Today we've got three speakers who will be discussing various aspects of what we know and don't know about the origin of infections in Ireland, particularly of new variants. And this is, of course, very important going forward if we're to design a strategy that is to maintain low levels of SARS-CoV-2 infections in Ireland. We have to know where they're coming from. And this is particularly pertinent when we consider how much mobility between Northern Ireland and the Republic of Ireland contributes to infections, and similarly how much travel across the common travel area contributes to infections. But before we hear from our three speakers, we'll first discuss the current ISAG situation analysis, and this will be presented by Dr. Paul Dempsey. So Paul, when you're ready.
Thanks, Tomás. I suppose, first of all, we'll look at Northern Ireland, and their cases have been steadily going down since just after Christmas. We might be even able to see some signs of a very slight vaccine impact in the over 80s. These charts, as in previous weeks, are done on a logarithmic scale so that we're able to see trends develop easier. So by logarithmic scale, we mean instead of just going 1, 2, 3, 4, 5, we'd go 1, 2, 4, 8, 16, up like that. It's a different scale, and it represents how viruses kind of spread, replicate in that pattern. So again, we see this tiny little hint of a vaccine impact in Northern Ireland, and hopefully we can see more of that in the next 2 or 3 weeks. In the Republic, we're just looking here at healthcare workers are the blue line, and the rest of us are the orange line. Healthcare workers has had a very substantial drop in the last couple of days, week to days. Whether it's an impact of the vaccine or not, we won't really tell straight away because it can be variable, but it is still very nice to see them going down to closer to the level of the general population. On the other hand, the general population, the case numbers have been kind of getting a little bit worrying in the last little while. So we can see here the orange line. It had been going at a steady, but slowing rate. But in the last little while, it has gone further up. Now, close contacts could explain some of this, but if we, based on what we've heard from Professor Nolan from NEFIT, that really shouldn't account for a small rise over where this trajectory was going. So around there, so we have a little bit again, but with publicly available data, or even the data that seems to be available to NEFIT, it's hard to tell what is what exactly. But there could be. So that's on the national level. When you look down through the age groups, one thing that might be clearer from close contacts is that the rate in children has started to increase pretty much in line with when they start re-kicked close contact tracing. But there have been some increases in the 15 to 34-year-old age categories much later, and also a steadying of the ship in the 35 to 64. And we'll see in the next little while whether that changes. And now some of this could be community-based, or some of it could be outbreaks. So trying to read too much into it at this time can be difficult. But trying to see where things can go wrong, it does appear that there might be a big difference in between regionally across the country. So in Dublin, we're getting to a case where it's very close to going back into growth. So this point here, when things, so the rate of decay started to slow down in a very, very predictable fashion. At this point here relates to probably by around January the 11th or January 8th, somewhere around that period. So pretty much once people started going back to offices after the Christmas break. But that doesn't explain the whole country. So for example, if we look at Cork and Kerry, things have been going steadily down. One reason for this could be differences in the B117 variant across the country, but we have no data on that to be 100% sure. But based on movement patterns around the country, so if you look at, say, Apple data, where you can get a better breakdown, there doesn't seem to be much differences between Dublin and Cork. But looking at Google, we've been very steady and haven't changed in any way since the start of January, well, since middle 11th of January, suggesting there's nothing to do with fatiguing or anything like that. It's literally just, it is most likely a result of increase of B117. Now, this is fine for now. Well, it's not fine. It's a bit worrying right now, but it's not. It could get a little bit worse if we were to allow in the Bristol variant or variants which have this E484K mutation, because at the moment we're getting a hold on these increases because there's a portion, maybe 10-ish% of the population who are already infected, and that reduces the replication rate. But if the variants get in that allow for reinfection, that protective barrier is gone, and we're kind of like back in a restart position. So we need to take action to make sure they don't come in before they take hold. Okay, thank you.
Thank you very much, Paul. Obviously, very serious situation, particularly in Dublin, even under the current restrictions. We can come back to that issue in the discussion after the three speakers. Our first speaker of today's webinar is Professor Sam Scarpino. Sam is assistant professor at Northeastern University in Boston. He's also an affiliate of the Santa Fe Institute in New Mexico. Sam is a systems biologist and complexity scientist, and his work has been pioneering, particularly within the context of the COVID-19 pandemic, in how him and his group have been integrating mobility data of populations with the epidemiology of SARS-CoV-2 infections in different communities. And he's published extensively on this, on analysis, particularly in Wuhan, very early in the pandemic, also in Mexico and in other regions. And today he'll be talking about how he's applied this analysis to the island of Ireland and the common travel area. So thank you for joining us, Sam, and you're very welcome.
Great, thank you so much, Tomás, for the kind introduction, and the rest of the panelists for the invitation to join the group this morning, and everyone attending. Thank you very much for your time. I know that these are challenging decisions that we're all faced with, but I think ultimately understanding how we get past COVID-19 is critical for our lives and our economies. And so I'm very happy to contribute a little bit of the work that we've been doing over the past year or so. Starting from this time last year in Wuhan, China, one of the things that is important to remember about COVID-19, although we weren't calling it COVID-19 then, is that when this disease takes hold in a large metropolitan area, mobility in and out of that metropolitan area can sustain the epidemic in suburban and rural areas surrounding the large city. And this is a pattern that has played out again and again and again globally. And we're seeing similar signs of the B117 variant in terms of its establishment in London towards the end of 2020, and then the movement throughout much of the UK and Europe as a result of the establishment in a large metropolitan area. So we tracked this in Wuhan starting in January 2020, looking at the mobility patterns out of that city as the cordon sanitaire went into effect, as the lockdowns went into effect throughout China. So this is what we're seeing going from January 1st through the beginning of February in 2020 in red, 2019 in gray, mobility from Hubei province, which is the province around Wuhan, out into other provinces. And so you see, as you approach the dashed vertical line, which is the quarantine or cordon sanitaire of Wuhan, you have a sharp decrease in mobility, and then eventually essentially no mobility in and out of that province, nor much in the way of mobility around the local areas. And what we saw very clearly, and this again is played out globally in terms of the effect of these kinds of interventions, both a combination of local non-pharmaceutical interventions and more regional restrictions around mobility to protect areas that either have low incidence or to isolate areas that maybe have higher incidence. So on the y-axis, these are the COVID-19 growth rates that we saw from Paul's talk. So positive growth rates means that the epidemic is growing faster. Negative growth rates means that it's contracting. The first 2 weeks of 2020, this is aggregated across all of China. We don't see much in the way of growth. The disease has not yet established. We move into the week just before the cordon sanitaire and the lockdowns, and we see really intense growth, rapid increase in the number of cases that then slows as soon as these non-pharmaceutical measures, non-pharmaceutical interventions go into place, eventually stopping and then turning around and coming back down very, very quickly as we see the effects of mobility restrictions and local non-pharmaceutical interventions designed to reduce the risk of transmission outside of the household. Globally, the effect of these measures has been heterogeneous, not in terms of how well they work, but in terms of how successfully they have been implemented, in terms of the political will to drive COVID-19 to zero, in terms of the political will to not accept anything less than complete local elimination of COVID-19. But we also know that COVID is a local disease. And so as you are familiar with across countries, within counties, within local areas, the prevalence and presence of COVID-19 can vary quite dramatically in space and time. And so one of the things that we have to understand is that we have these large regional differences that are quite often organized around the kinds of non-pharmaceutical interventions that are in place. But then once you actually have epidemics within a country, you often have a great deal of heterogeneity across space and across time that are affected by things like differences in social networks in urban versus rural areas, mobility patterns, and heterogeneity in interventions that are in place. Now, importantly, depending on the particular mobility environment that you find yourself in, you're often both connected locally and more regionally. So now we're looking more regionally across the two islands, and the colors here are related to the epidemiological zone that different regions are in. So we're using a combination of case data and a variety of different mobility data sources. So you could think about tracking information from Facebook and other smartphone apps, airplane flights, all of the sorts of different ways in which we're connected via mobility. And what you should take away from this map is that you have many different pockets in terms of epidemiological zones, but also quite a bit of connectivity between the major population centers across both of the islands. And one of the things that continues to strike me is how important reintroductions are for COVID-19 epidemics. It's not necessarily the case for diseases like influenza that reintroductions are as important, but for COVID-19, you both have to locally eliminate or locally eradicate COVID and then prevent its reseeding. And so this is an animation from. I think someone is off mute.
I think it was feasible. I think the population put up with it. I think the government understood. I think
Andrew, I think you can mute Anthony as the host.
So let's see. These are reintroductions in Scotland. Their estimate in this paper was that there were 200 separate introductions that drove one of the most recent waves of COVID-19 in Scotland. So repeated introductions in order for this disease to become established. Now, comparing these epidemiological zones across the island of Ireland, there are two things that really jump out at us. And so what we're looking at here is just the percent change in the Republic of Ireland and then Northern Ireland. And in the Republic of Ireland, we're looking at the electoral districts. And so you actually have kind of sharper changes because you have smaller areas. So a lot of the kind of in blue, a lot of the swings in the curves here are because we're looking at smaller geographic regions. But what I want you to pay attention to is that in this fall wave, a lot of the red lines and a lot of the blue lines are kind of on top of each other. And we'll see this in a graph of the island here in a second. But two distinct kind of time periods, one where Northern Ireland and Dublin are highly synchronous with each other with respect to mobility and COVID-19, and then a second wave around Christmas where there's more distinct separation. And so it's really going to be a combination, as I alluded to, of local measures and regional coordination that are going to allow for the elimination of COVID-19, and that varies in space and time. So just zooming out and looking across the entire epidemiological time series from the spring up until the present, there are three distinct epidemiological zones on the island, and we're identifying these by looking at how synchronous the outbreaks are and looking at mobility data across the island. And you see there are three distinct zones that show up indicated in the different colors. And so across the entire past 12 months, you have these three different areas that tend to have their own dynamics with respect to COVID-19, although they are of course linked to each other by mobility, and they are linked to each other in terms of the reintroduction of cases. However, in the sort of September, October timeframe, one of the things that jumps out is that Northern Ireland and the area around Dublin are highly synchronous with each other, such that there was a concurrence in the timing of their COVID-19 epidemic wave, and this shifted into the Christmas peak, such that Dublin then clusters with the rest of the Republic of Ireland, and you actually see Northern Ireland clustering with England, Scotland, Wales to an increased extent. And so one of the things that I think is really an important take-home message from the work that we've done so far is that depending on the particular wave that we're talking about, there are different patterns of connectivity across the island that have to be accounted for. And so you're going to need to have both local strategies that account for the particular dynamics that are happening locally. It's one of the things I mentioned in the last webinar that I participated in, that a lot of the Christmas wave was driven by the introduction into rural areas in the Republic of Ireland that had previously had low rates of COVID, and then increased mobility in those areas that drove local outbreaks. And I think that has quite a bit to do with why we see this map on the right, where you have a lot more local dynamics driving, whereas on the left, you have a lot more regional dynamics. So again, this interplay between local and regional dynamics, the importance of reintroduction, and the need for both non-pharmaceutical interventions that are targeted at specific areas, but also regional coordination that handles the reintroduction of cases and the synchrony in attack rates that can happen as a result of mobility. And so just as a final reminder, mitigation strategies do not work. There is essentially no evidence that mitigation strategies are able to protect the economy, nor are they able to protect individuals' lives and health from COVID-19. So this is just an example of data coming out of University of Oxford's Our World in Data, showing essentially the stringency index from 0 to 100, how intense the lockdowns are, how intense people's lives are affected by the non-pharmaceutical interventions, comparing Canada and New Zealand. And so you see Canada's at this persistent level of unpleasantness basically for the past year, and they have been hit hard by COVID in essentially all of Canada except for some of the Atlantic provinces that have gone for a COVID zero strategy. And compared to New Zealand, which has had shorter bouts, as we're hearing now, of very intense non-pharmaceutical interventions, but those are interspersed by live football matches and effectively normal life and normal economy. And so overall, they have both done a better job of protecting lives, protecting economies, but also in terms of people's mental and social health, which cannot be understated. I'm sure it's something that all of you understand. And so take-home messages: controlling COVID-19 requires local and regional coordination as a result of both the specific environment that local areas find themselves in with respect to COVID-19, but also the importance of reintroduction and the kinds of regional mobility that we know happen across the island of Ireland, across the UK and the rest of Europe. Interregional mobility matters, but local mobility is equally important. So you need a combination of strategies that take account of the local dynamics, the local effects of COVID-19, and also the regional coordination. And rebuilding our lives and economies requires controlling COVID-19. There's essentially no evidence that you can have one without the other. And so in particular for this talk, I'd like to thank Brennan Klein, who is a postdoctoral researcher at Northeastern University, who helped me prepare many of the graphs and analyses. They both say Brennan Klein. That is a big mistake. The individual on the right is Moritz Kramer, who, very sorry if you're listening, Moritz. Moritz Kramer is a research fellow at the University of Oxford and is one of the co-leads of essentially all of the COVID-19 work that I've been involved with. And then we're embedded in a much larger team of researchers internationally who have branded themselves global.health, who are working on the kinds of mobility, high resolution case data, non-pharmaceutical intervention studies that Tomás mentioned in his kind introduction. And with that, I'd like to thank all of you. I'm not going to take questions now, but I will of course stay around for the rest of the session and the Q&A. So thank you.
Thank you, Sam. I'm sure there'll be many questions on your talk from the panel and also from the attendees later on. Our second speaker is Professor Aoife McLysaght, who is Professor of Genetics and Director of the Molecular Evolution Lab in the School of Genetics and Microbiology at Trinity College, Dublin. Aoife is also a member of the Independent Scientific Advocacy Group. And Aoife will be discussing what genomic analysis has told us about SARS-CoV-2 seeding in Ireland and the risk of new variants.
Hi, okay, I think you should be able to hear me now. As Tomás said, I'm just going to give a bit of a summary of the genomic analysis. And the main thing I'm going to be talking about today, I'm going to be relying on this particular paper that you see here. If you're interested, this is freely available. This is the work of Professor Paddy Mallon and colleagues in UCD, and well, he's in UCD and he's got colleagues in UCD and around the place. He wasn't available to join us today, so I'm going to talk about this. But essentially, the point of this is thinking about what can we learn from the genomic surveillance of the virus and the pandemic. And this is something we've all been getting used to, I think, because there's been really extensive genomic surveillance of this pandemic, especially in the UK. I think about half of the genomic sequencing that's happened has been done in the UK. So that's why we have such good data on what's happening there. And there was less data on Ireland, and this paper then is filling that gap. And so they have been looking at sequencing samples from patients in Ireland and looking at what they can learn from that. So this is basically what we all know already. This is information from the Irish government COVID hub. And you can see here we have the first wave, the second wave, and then the third wave that we're currently in. So what they did in this paper to try and understand what's happening, what has been happening in Ireland under this pandemic, is they sequenced 225 samples. So these were samples that came from patients. It was in 4 different hospitals in Ireland. 3 of those were in Dublin and 1 was in Wexford, I think, Wexford or Waterford. But it is an East Coast and Southeast bias, if you like, in the data, and that may or may not be relevant. Of these 225, they got 134 basically from the first wave, and the rest of them came from the second wave. And that also allowed them to think about, you know, what's the difference between the 2 waves. So as we are all very aware, we got our numbers really low last summer, and that was a huge success of the first lockdown. So we got down into very consistently extremely low numbers. And as we are also painfully aware, there was a second wave and then a third. So a question that we can address with the genomic data is, you know, what caused the second wave, what caused the third wave. We can start to understand how did this happen, because that tells us as well how we need to protect our gains. You know, when we make these achievements, when we achieve low numbers from a lockdown, what do we need to do to protect that position? And so essentially, you know, if here they only had data for the first and second wave really, and third wave was just a little bit too recent for this paper, but they're essentially asking the question, you know, what caused the second wave? And we have basically two options, and a mixture option. So either, you know, one option would be that we got those numbers down really low, but not all the way down, and maybe that was enough when we relaxed restrictions. Maybe the little remnants of the first wave were enough to start things, kick things off again. That's one possible option. Alternatively, our first lockdown could have been entirely effective in terms of eliminating the virus from Ireland, but we started all over again by letting it back in again through travel. So people going out and coming home with the virus, or people coming on holidays here carrying the virus, or it could be some combination of those things. That's also possible. So this is what this work set out to measure. And basically by sequencing the virus, they can compare it, and you can group the virus genomes into families. So it's very like a family tree you'd see for humans. You can see the relationship. So this virus mutates at roughly 2 mutations per month, something like that. So you can track the virus relationships. You can see the ones that have smaller number of differences between the genomes are clustered closely, and those with more differences are further apart in this family tree. And so by doing that, we group them into these categories, and we give those little labels that we've kind of got used to. So there's multiple labeling systems, but we've mostly been using this one with the letters and numbers. And so B117 is the one that people have got used to the name for lately. So that's the so-called UK or Kent variant. So we can call it the Kent variant, because now there's also the Bristol variant that we're interested in. So if we look at that, if you look at that as an example, you know, that wasn't here at all during the first wave. So we have the date across the bottom here, and that B117 is totally absent in the second wave. And then of course it's appearing here just in the end of last year. So you can see how this data can tell us something about the virus. And if you look in this picture, this is our first wave period in the dates across the bottom. So these are just weeks across the bottom. And what you can see is they've colored here in this paper, they've colored the first wave dots blue and the second wave dots orange, yellow. And you can see the size of these circles tells you about how many of that particular variant were found on that week. So if you look, you can see this variant, which was a number we never got used to because we were never using these numbers last year. There were lots of cases of this variant across multiple weeks. There were lots of cases of this variant across multiple weeks as well. And so you can see that these variants were the main ones that were there in Ireland during the first wave. And so we can see this very clearly in these data here. But then if you look at these same variants, these ones that were really important in our first wave, and look at what's happening later. So let's just take this one, for example. And if you go across, this totally disappears from Ireland. So this variant that was really important in driving our first wave is totally absent after that. And the same for this one here. It's totally absent. It was just found again in December, one case, but it was absent in the intervening period. And you can see that really for across the blue variants. So if you look at these particular variants, the ones that were there in our first wave were absent in our second wave. And that tells us that we were actually very successful in eliminating the virus from Ireland. So it was at least based on these data, it was not the leftovers of the first wave that caused the second wave. Those viruses, those strains that caused the first wave were completely eliminated from Ireland. And when you see the second wave, it's quite obvious that it's all up the top here in this particular variant. So this one that's called B177, it's totally absent in our first wave. It's not in Ireland, according to these data anyway. So, you know, this is not 100% sampling, but it's a good sample. But in the second wave, it's essentially, it's nearly everything, right? So it's really, really driving the second wave. So I think what you can see here from this genomic analysis is our first lockdown was very, very effective. It eliminated the virus from the island, as far as we can tell. And then we started again from scratch by importing the virus all over again. And so this B177 was first identified in Spain. It was identified in Spain early on, and so in the kind of late spring, early summer last year, and then it quite quickly spread throughout Europe after people were allowed to travel again. So this particular picture is from another paper that's also freely available. You can look it up there if you want. And this is examining kind of across Europe. And you can see on the top here, they're pointing out travel restrictions, where and when they existed and didn't exist. And this is kind of this is again the time going across the bottom. And so on the top, they're showing when travel was allowed. And you can see that when travel was allowed, this graph, which is showing you all of Europe, went up quite quickly. This one here, this green line, is Ireland. So you can see that where this variant was absent from Ireland, once people started going on holidays, it eventually came to Ireland. So this is quite plausibly Irish people going on holidays and then coming home inadvertently carrying the virus. So it's possibly more likely that than the other way around, and just in terms of the way our tourism industry was operating, especially last summer. There weren't too many European visitors coming, I think, but I think quite a number of Irish people were understandably eager to get away, but it wasn't necessarily the right time to do that. And so this could have come directly from Spain, or as it spread around Europe, people going to other parts. And more than that, so this variant B117 caused our second wave largely. And the other thing that this paper showed was, you know, we can ask the question, did this happen? Was it one unlucky person carried this, or was it over and over again? So this picture is probably not that easy to understand totally at a glance, but it's essentially, it's one of these kind of family trees that has been twisted around into a circle to make it fit onto the page. So you can see, you know, a relationship. So this virus variant is related up, and these are related to each other by these lines that link them. You see that kind of thing. And in this picture, Ireland is colored green and the other countries are given their own colors. So this is only showing this B177, this one that was first identified in Spain. And if this had been reintroduced to Ireland once, you would expect all of the green ones to form a little family of their own, because they would all be related to each other more than anything else. It would have got to Ireland and then spread a little bit, maybe changing a little bit along the way. But as you can see, the green is in multiple places. So we've got the green in multiple places. So this is an example of where it spread in Ireland and diversified a bit, but it didn't come from the same origin. We've got all these multiple origins. So we actually reintroduced the virus, this specific strain, many, many times over and over again. And we know now, of course, that we in December imported the B117 variant, which is now our dominant one. Based on the latest information from NEFIT, it's at least 75% of our cases. And whereas the B177 was not considered to be more transmissible or anything like that than any of the others, its spread was just, it was just so. the B117 is more transmissible, and so it's more of a significant challenge. But so that's all really I wanted to say. It's just, I think it's useful to have this information. We've previously had information that was Europe-wide, but this was more specifically focused on the Irish situation. And I think it's very clear from this data that our first lockdown was extremely effective. We did eliminate the virus almost completely from the island, and then we started all over again by bringing it back in. So I think it shows very clearly that we do need to protect our gains when we start winning against the virus in terms of crushing the numbers. That's something we need to protect, and that's how the quarantine is what works there. And this case, we imported them again from Europe. And just to be aware, so those numbers are very hard to remember, like the B117 we've got used to, but the B177 and the B1351, it's more convenient and it's easier to remember the South African variant and the Brazilian variant, but that doesn't necessarily make sense because that's where they're first noticed. It's not where they are today. And we see that these spread. And so you can't protect yourself by just making a list of countries after you've noticed where things are. So Austria is now on our list for quarantine, but that's because the South African variant has been discovered there, but it's also in other European countries. So I think that's an important point to remember. So that's all for now, and same as Sam, I'll be around for the questions afterwards.
Thank you very much for the extremely lucid description, Aoife. I think it has to be emphasized that up to a week or two ago, we had a complete lack of knowledge of both of the two previous presentations. We had the guiding principles. It's ubiquitously known internationally that SARS-CoV-2 is obviously introduced by travel. We knew a lot about the genomics of it around Europe, and obviously human mobility regionally and locally drives the spread of the virus. But apart from knowing those two principles, those two guiding principles, we actually did not have the facts about Ireland until the study that was done under Paddy Mallon, and now the analysis on mobility done by Sam Scarpino, which is yet to be published fully. What does this tell us? It tells us that we did really eliminate the virus, effectively eliminate the virus over the summer. And it wasn't because we had the hardest lockdown in the world. And it wasn't because we had the most successful first lockdown in the world. We did suffer a lot of deaths the first time. It was because we're an island, largely. And that's why we had amongst the lowest case numbers in Europe in the middle of the summer. And it's very clear now that seeding from Europe of what we can call the Spanish variant caused our second wave. Furthermore, it's clear that opening up at Christmas the way we did, though it was not caused by the Kent variant, it allowed the Kent variant to take over. And because the Kent variant is so much more transmissible, it is now the dominant strain in Ireland. And this is likely the reason for the harrowing results that we saw in the first presentation by Paul Dempsey about how we're struggling to control this variant, or seem to be struggling to control this variant even under the current restrictions. And this is going to be very important for how we manage things going forward. But also with respect to north-south mobility, we've been working so far under the challenge of how to manage Northern Ireland, but at the same time, or how to manage the interaction with having two jurisdictions on the island. But at the same time, we've never really had any information for how Northern Ireland is contributing to infections in the Republic of Ireland, apart from static commuter maps that from the Central Statistics Office that predated the pandemic. And the kind of analysis that the Scarpino group has done is showing us that maybe most of the mobility that is causing infections from Northern Ireland is contributing to Dublin, but perhaps not other regions directly. And we need to look at this more closely and to try and figure out how much Northern Ireland is contributing to different epidemiological regions of the Republic of Ireland. And I think this is I'm sure we'll come back to that after Tony's talk and Sam can comment, but I think what's a salient point about this is that one of the reasons for having defeatist strategies in Ireland around COVID-19 elimination is because, is there anything we can do about Northern Ireland? But it seems increasingly clear that if we deal with every other problem, every other source of the virus, first in the Republic of Ireland and also by international travel, then would there be a lack of motivation to manage the Northern Ireland border? And I think many of us would say that probably not. Probably there would be a lot of motivation to find proactive ways of managing the Northern Ireland border. Now, our last speaker is Tony O'Brien. Now, Tony O'Brien is former Director General of the Health Service Executive in Ireland. And he needs no introduction for any of the people here who are watching from the political world or from the journalistic world. He wrote a very provocative or prescient rather article, I would say, at the beginning of 2021, arguing that Ireland needs to take a zero COVID orientated approach, whether we do this as the Republic of Ireland or whether we do this on a one island or a two island basis. And when we hear reasons for why we can't do this, we often are told that it's not possible to implement this, or we're told by the people who are responsible for implementing different aspects of our strategy, political reasons for why we don't want to do it. And so this muddies the water of the conversation to a large extent, because we're not always clear when we're having this conversation about what is possible within the Irish context. Obviously, every country has to find their own way of implementing an elimination strategy. So Tony, please start whenever you're ready.
Thanks very much, Tomás, and good afternoon. I'd like to, first of all, thank you for the invitation to take part. I'm not a member of ISAG, but obviously I've followed the work quite closely. And I think today's three presentations by three very excellent speakers really do demonstrate the value of having an open debate that embraces emerging evidence and seeks to utilize it as we go through this process. And I think that's really important because, in my view, we're probably now in one of the most difficult phases of this in terms of social cohesion and the understanding of society for the ongoing measures that we're all having to live with, which are indeed increasingly difficult as we approach the first anniversary of the first lockdown. So we're all experiencing fatigue, exhaustion, and so on. But in my view, and I think it's important that we have a discussion that's not based around blame and recrimination, but is about learning and looking forward. Because what we have seen progressively as we've gone on with this is that things that at an earlier stage were considered absolutely undoable are now being done. And we see that now with the introduction of compulsory hotel quarantine for people traveling from certain countries, yet to be fully implemented. But 6 or 8 months ago, that was characterized as being impossible. And I think what we are learning, and today's evidence supports that, is that we can't outrun certain decisions. They're decisions that are going to have to be made. And the whole question of quarantine in the context of a pandemic should never really have been a great surprise to us, because we've known since the 14th century that quarantine is an effective mechanism for allowing travel, but allowing travel safely in a way that protects the population of the destination, port, city, or country from the risk of infection being brought from other places by people through no fault of their own, simply by virtue of travel. So quarantine, it seems to me, is an inevitable part of this. And we also know, and this again is the reason why I think it's important to have an independent group, we also know that NEFET has, in its own quiet way, in its letters, been indicating with increasing concern that the level of discretion around so-called advised self-isolation or quarantine is a major flaw. So to those who tend to characterize the kind of zero COVID debate as a kind of bunch of absolutists on the one side with no concern for people who have to travel for whatever reason on the other, I think that's a completely false narrative, and it's really damaging. And I'm supporting a pretty strict, tough regime on quarantine as someone who has made an essential journey to another jurisdiction and then come back and then rigidly self-isolated myself, but knowing, as many of us do, that there are other people who have taken that discretion as a license not to self-isolate and who may have inadvertently infected their family members or other people. And we've seen that on the chart today, that there are variants first identified in other locations which have become the dominant waves in our second and third peaks in Ireland, which could not have happened if we had had a more effective quarantine regime. It's really as simple as that. And as we go through this, we are going to see more and more new variants, and those too will come here and become dominant if we don't find a means of effectively controlling or quarantining until such time as people have either manifested an infection and got through that infection or whatever. So there is an absolute inevitability about a progressive move towards stricter measures. Now, in the world of politics, and I suspect there are many people here listening from the world of politics, directly or indirectly, there is a necessary precondition, which is around being attached to certain red lines and trying to do everything to hold on to them. And I think that the debate around zero has perhaps given too much excuse to people to think that we don't have to do these things because zero perhaps is considered unobtainable. But what I would say is that the word to substitute for zero, or the idea to substitute for zero, is maximum suppression. I think we can all agree, whatever our perspective on how we got here or where we're going to go, that the name of the game is maximum suppression, using the internal lockdown arrangements that we have had, using control on entry into the country, using vaccination strategies and so on. We must do everything that we can to achieve maximum suppression. And while constitutional politics on the island may limit some of the things that we would ideally do, they absolutely cannot provide an excuse for not trying. I think to fail to try is absolutely a recipe for disaster. And the other key issue that's often thrown at this debate is that there's kind of an absolutist thing that thinks we can have absolutely zero travel, absolutely zero movement in the country and so on. And actually, the aim here is the reverse. The aim is to create safe mechanisms by which people can travel without carrying new variants into the country, and to create an environment, as some other island nations have done, where there can be a much more significant return to normal life than any of us here on this island are enjoying. And the longer we carry on with this type of cyclical lockdown, the greater population resistance I think there's going to be to compliance with that, and they will become increasingly less effective. Yes, we've seen additional measures, additional fines and so on, but that is not going to be sustainable if we still have an environment in which people from most countries in the world can still come to Ireland and effectively be at their own discretion as to the extent to which they control their own movements. That is simply not a sustainable equation for the country. And while some may say, well, look what we've done around Brazil and other countries and Austria now, that's grand. But that's shutting the stable door after the horse is bolted. These variants are only identified in countries retrospectively. Travel has already occurred, and those variants are almost certainly already here before we add those countries to those lists. So my central point that I'm trying to make as part of my contribution today is that everything that is considered too far, unless we do some of those things, we're going to get to them eventually. But we're only going to get to them when we have done significantly more damage in terms of the illness impact on our country, the deaths that arise from that illness, and the economic impact that is very sustained and substantial right now, and is going to have very long-term implications for many individuals around their livelihoods and their sense of well-being and so on. So to politicians, to those who are making these decisions, and I don't say this to be harsh or critical because I recognize that it's a very difficult place to be, weighing all this up and making those decisions. Just look back over the last year. Think of all the decisions that are now being made, now being implemented, that you considered impossible to contemplate a year ago. They're now being done. Look at the next set of things that will have to be done and just think of the benefits of doing those things more quickly. Having those tough discussions. We're either going to have to do this as a country, as an island, or as two islands, but one way or the other, we're going to have to do this if we want to get through this. The vaccination is a really important, welcome development. And the fact, obviously, that Janssen have applied for market approval yesterday is very significant. But we simply cannot assume that vaccination is the panacea, because there can be new variants which alter the game. There can be unexpected delays in the delivery of those vaccines. The path is not absolutely clear or straightforward. And even if it is, we know that path runs out for many, many months ahead. So I would argue that the more debate we have about the ideas being put forward by ISAG, the better, and the more readily we are to embrace those things which are the most difficult to do as soon as possible, the better the outcome will be. Thanks, Tomás.
Thank you very much, Tony, for the incredibly clear and forthright assessment of the situation. We're going to move to questions now. I would just summarize first by saying it's very clear based on the science what needs to be done. We need to have international travel quarantine, for which there is widespread public support for. It's not just about what countries the variants are in, the variants are on tour, but also with respect to how they travel here. We don't have direct flights from South Africa and Brazil to Dublin. So you have situations where literally a person who is flying from Rio de Janeiro or Cape Town is sitting beside someone on the airplane who is flying via the middle city. So if you're changing planes from Portugal to Brazil, from Brazil to Portugal, on the Portugal to Dublin flight, the infected person is sitting in the region of people who are not going to be quarantined under current arrangements. One of those two people can be talking, eating together, and then when they arrive in Dublin, one is quarantined and one is not. That's not a sensible arrangement, and we have to move towards mandatory quarantine for all incoming travelers. And this is widespread support of 90% of the Irish population. On the subject of how we actually get down to elimination, when we have these case numbers, the only way we can do it is by restrictions. And the harder we go, the faster we get there. We need to find ways of making this lockdown more effective. And we saw from polling data at the weekend that over 60% of people in Ireland want this lockdown to continue until we are under 10 cases a day. Another 25% of people want to stay in lockdown until we're under 100 cases a day. So when we hear narratives about opening up sooner or needs to open up sooner, we must be careful not to be distracted about this. People do want to crush this curve. They do want to eliminate this virus. The third thing we need, which maybe Tony will be able to comment on in discussion, is we need to resource public health. When we hear the reasons why we can't do zero COVID, we hear that we can't shut off international travel, that we're a highly connected economy. So are New Zealand and Australia and South Korea. We hear about the North, but that seems to be more of an excuse than a problem, and we can discuss how we manage that. But the only medical reason that has been given for not going for zero COVID has been given by NEFIT. And the reason has been that our public health infrastructure is not agile enough to pounce on outbreaks. Now, a year into the pandemic, many of us think this is not a sufficient excuse. We accept that public health medicine in Ireland, unfortunately, has been neglected for a long time. But given that we only have 60 public health physicians working in the country, we should be able to find innovative ways of rapidly resourcing them such that they can manage outbreaks when case numbers are low, when case numbers are below 10 cases a day. Now, with respect to the discussion, I'm going to field questions from the panel and also from the participants, so from the attendees. So if you want to ask a question, please place it into the chat window. But I think the first question needs to go to Sam Scarpino, which is on the north-south analysis. I think it's really important to know whether we can say how Sam, your analysis was so clear with respect to how Dublin correlated with Northern Ireland before we hit the third wave, before we hit the Christmas wave. But I think a lot of people want to know how much of Northern Ireland is contributing to infections in the Republic of Ireland outside of Dublin. And throughout the pandemic, before the third wave, when we think about the second wave and the seeding that occurred after summer, was Northern Ireland contributing mainly through the Dublin-Belfast corridor, or do we think about Northern Ireland and the Republic, and do we think about Northern Ireland and the Republic of Ireland as separate epidemiological zones other than the Dublin relationship?
Well, that's a great question. To the extent that we can tell whether there's additional effects of seeding from Northern Ireland outside of the signal that we see with Dublin. One of the so the kinds of methods that we use are highly effective at picking up the regional patterns. And as we saw with the Christmas wave, you can often pick up if there's evidence for widespread seeding, as we saw coming primarily from Dublin into more rural areas in the Republic. However, it's because we're not working with individual level case data that contains travel history, it's difficult to build a statistical argument around whether there may be additional seeding that's happening, say along the border or into other parts of the Republic. I think that the kind of genomic analysis that we heard would be able to answer that question in potentially if the sampling is done well, and especially because the UK has fairly dense sampling in terms of their genome sequences. So I think if we really wanted to dissect that question and look a lot more fine-grained, we would either need individual level line-list data, ideally that had some indication of travel history, or we would need to incorporate the genome data, which could be done. But this is a kind of a long, now rambling answer to say that I don't think we are able to see that specifically, given the kinds of analyses that we've run so far.
Okay, thank you very much, Sam. On that subject, I would note that the Hodcraft paper that Aoife McLysaght presented as part of her contribution found that the B117 variant, the Spanish variant, was not as prevalent in Northern Ireland as it was in the Republic of Ireland post the summer. So I wonder, do we currently have genomic analysis or insight into this? Is that still the case post second and third wave?
Are you asking me, Tomás?
Yes.
So I'm not sure if we have that data, and just in terms of, you know, how much the genomic surveillance is really, really useful, but it also, for us to notice a pattern in terms of, let's say a virus was in the variant was in the UK, then went to Northern Ireland, then arrived in Dublin. In order to be able to notice that, there needs to be kind of enough time in between the steps, because like I said, the virus mutates at around about 2 mutations per month on average. And let's just say that did happen. It was carried to Northern Ireland and then to Dublin. You wouldn't notice that if it happened very quickly. You wouldn't be able to tell the difference between it coming directly from the UK. So it depends on how tight those links are, whether the genomic surveillance would answer some of those specific questions. It's probably more likely that the retrospective contact tracing would be informative there.
Mm-hmm. Okay.
I could add very briefly that, you know, in terms of the airline flight data, you do see an increase in around the Christmas time period in terms of the connectivity between London and many different parts of the Republic of Ireland. And so I think that would be consistent with B117 coming in via that route. Although, again, in this case, we're making a statistical argument, which I think is valid in many settings, but in terms of the kind of detailed case investigation that we're sort of talking about, that really the shoe leather epidemiology is almost certainly going to give a more robust answer.
And B117 is about the same north and south. But it's going to be everywhere. Like, it's the same. It's so much faster. It's going to outcompete everything else. So it's not really that easy.
Mm-hmm. Yes, the new variant is in both north and south, but I suppose the issue is whether not the new B117 variant, but the Spanish variant did seem to show different distributions, and whether we could get insight as to whether that was coming from, whether we have in parallel seeding from into the Republic and Northern Ireland from Great Britain, or whether it's more integrated as one zone. It seems the answer is we don't fully know. So the next question is one relating to vaccines. And I think that this is going to be a topic of a webinar that we will do in a few weeks on expectations for what we think that vaccines are going to be able to do to reduce transmission in the community. But the specific question is, could high vaccination rates in Northern Ireland, the vaccination rates are currently higher in Northern Ireland now than they are in the Republic of Ireland. Will that help to bring down levels here, assuming vaccines reduce infection and not just serious illness and mortality? Who would like to take that question? Paul?
I can say very briefly, I mean, what we're seeing in Massachusetts, where the vaccination rates are starting to get quite high. So we vaccinated about 10% of the population with the Pfizer and Moderna vaccines, but those have been targeted towards healthcare workers and individuals that are at highest risk. We're seeing the early effects of that. So long-term care facilities, which had previously been an epicenter for outbreaks, have been dropping precipitously over the past few weeks. I think there is some preliminary evidence across the UK that you're starting to see some effects of the interrupted transmission. So things look optimistic, but of course, the vaccines work better when there's less COVID, and it also prevents or gives us the best possible shot of not having one of the other variants that where the vaccine may be less effective. So B117, the vaccines seem to be fully effective, but there are other variants out there we know where that may not be the case. And so taking the opportunity now to prevent that from happening is critical globally.
Okay. So a question for Tony O'Reilly. In your opinion, do you feel that COVID-0 approach is being played down by the authorities, because if successful, the continued approach of living with the virus would then be seen as the incorrect approach, which would lead to uncomfortable questions being asked about decisions which were previously made?
As the Tony O'Brien, I assume that's for me. I think it's more a case of letting perfection be the enemy of the good, and a feeling that getting all the way to zero is unattainable, and therefore a reluctance to make moves in the right direction. I think there's a dividend from every move made towards so-called zero, and while there will be challenges, inevitable challenges on a shared jurisdiction island that might mean we cannot get to a perfect zero solution, there will be a dividend from every step made in the right direction. I think it is less a case of being worried about seeing to do something now that's different to what was done before, because we're seeing so many things. That's actually one of my central points, is that we're now seeing things being done which were impossible, allegedly impossible, very recently. So I'm just urging those currently responsible for making these decisions to revisit everything they've previously said as being impossible, and do it sooner rather than later, given, in my view, it's inevitable we're going to get to those things, but we'll have paid quite a price for delay.
Okay. Thank you very much, Tony. So one question which I think is pertinent for Sam is there any scope for allowing travel within a county or inter-county for the purposes of solo outdoor pursuits like hiking and fishing, these pursuits being safer and good for resilience and mental health and so on? And I think one thing that we've learned from your analysis more generally is the importance of local regional spread of the virus, that though initially seeded by interregional mobility, that local mobility is what's really driving this. And I think this is relevant for the 2 kilometer or 5 kilometer limit in Ireland. But I wonder what your broader comments are on this, Sam.
Well, first, I think the evidence is pretty clear that outdoor activities are much safer. Really, I think one of the things that's important is whether individuals only stay outdoors or whether they do other things when they travel, right? And so if you travel a little bit further to go hiking and you bring your own food and you are with individuals that are currently in your household, that may be safe. But I think in many cases, that's not what ends up happening in all of those travel events. So I think that there probably are ways in which you can design strategies that allow for outdoor activities, because I mean, they are critically important for all forms of health and much safer for COVID. But again, it's going to really depend on, I think, the local situation in terms of what other things are open and what individuals do when they travel, because as you mentioned, the reseeding is really very clearly seen, especially during the Christmas wave in local areas, rural areas that were previously less affected by COVID.
Okay, so question on how we're approaching this. So suppression, elimination, eradication, zero COVID, or Tony's suggestion of maximum suppression. Can we provide well-defined terms to use and reinforce, because there's a lot of confusion at present? Another question on the same topic asks about the difference between eradication and elimination. What are we going for? What is more practical? Is there anyone who'd like to, any of the speakers or other panelists who'd like to take that question?
I don't mind taking that one. So in terms of elimination and zero COVID are basically the same term. It's where you eliminate it from a specific region or country. So Ireland, for example, whereas eradication would be on a global scale. And I don't think even the most optimistic of us thinks that that's going to happen in at least the next 12 months, and probably may never happen. So I think where the confusion, and I may disagree with Tony on this one, between suppression and elimination strategies is what degree of reopening we want at the end of this. Do we go for zero or elimination and then try and reopen the local domestic economy fully? Or do we go for suppression, open up a tiny bit earlier, or maybe perhaps before we reach zero, and then only open up at level 3, and that could be a risky reopening at level 3 and then could lead to further lockdowns. So I think that's suppression and elimination do have quite different terms in terms of the official literature. So I don't think there is this perfect term that people are asking for. I think everyone has their own preference and their own loadings on what term they think. I think a maximum suppression can help for some people, but also hinder others. So I think it's a bit of a tricky topic on the naming of any policy. And I think zero COVID, despite its difficulties, at least highlights the importance of actually reaching zero.
I think many of us would think that zero COVID means also zero tolerance for COVID-19, that there's going to be cases, but that we are constantly putting out the fire entirely. Having a case, having a situation at zero is a lot more straightforward to maintain than having 1 or 2 or 10 cases, but when zero is a multiplier, nothing happens. Once you have cases there, in the absence of restrictions, you create the opportunity for exponential growth. I think it's important to return to what Paul was showing us today at the beginning of this webinar, which is the current situation in Dublin, because I think it's important to finish this webinar on a positive note before we close, which is how can we take control of this situation. It does seem that there's heterogeneity in the growth rates across Ireland. It's currently not clear how much of this is due to B117. But if we are to pursue a zero COVID strategy, or if we are to indeed to open up in any respect, it requires us to get case numbers down a lot further than they are at the current plateau. And of course, people are going to be concerned that we're currently in a very stringent lockdown. So what can we be doing differently in order to break through this limitation? And so I wonder, would Paul or anyone else or Anthony like to comment on this?
Well, I mean, it does seem to be Dublin led at the moment, but it looks like a particular region within Dublin. But we don't have any data to say there is regional variance of B117. It's just suggestions because of how low the effective R value is in Cork and Kerry, and how low it was before the outbreaks in other places in Mayo, in Connacht, in places like that. So it's nothing concrete. It's just suggestive that there's a difference. But to actually stop this, it's not much different. It's just a repeat of last April. Cork and Kerry may be able to exit it sooner. Dublin will take that bit longer because it's at such a high level and they haven't got the same head start that Cork. So the additional measures won't make as much difference in Cork and Kerry, for example, but any additional measures in Dublin could make a big difference. But also we know in Dublin, there's people going into the offices every day. Council workers are on three days in, 2 days work from home when they could be work from home. There's hospital HR, there's so much in the public sector realm that can be improved upon to try and reduce these cases. We know that there's no ventilation measurements. They're still waiting on that, still waiting on masking in offices advice, still waiting on all of these things that without making too much of an impact on people who are currently in precarious works. But Andrew, again, I suppose, who knows more about the occupational side of things.
Okay, thank you, Paul, for the very clear answer. Professor Anthony Staines would like to come in.
Just very briefly, at the moment we are in a somewhat improving situation, and it is getting better across the country, but is not getting better nearly quickly enough. There is a proposal to reopen schools in a week's time or 2 weeks' time. And we have a fair idea what will happen at our current transmission levels, that we will go from declining case numbers to increasing case numbers. Now, how quickly they will go up does depend on the mix of viruses. And it does raise a point that the data we're using to analyze all of this is very inadequate and very unsatisfactory. And data collection, it might cost 50,000 euros to collect the data properly. We're spending that before breakfast every morning on pandemic unemployment support. So we are not doing some of the very, very simple stuff that will manage this pandemic. We are not requiring most employers to keep non-essential workers at home. And I think Paul put his finger in it. It is largely public sector workers, it's civil servants, it's local authorities, it's administrative workers in the public sector whose managers have required them to come back to work. And there's very little point in all of that. So if we take this seriously, we can bring this to a much better place. If I look at Australia now, the last time I looked, there were 35 COVID cases in Australia. They were all in quarantine hotels. So that's the end game. We will have outbreaks. We've just seen an outbreak in New Zealand. Auckland was closed for a couple of days, which was a major pain in the neck for everyone in Auckland. But the outbreak is now over. The rest of the country stayed open, and Auckland is reopening today. So that's our future. That's where we can go if we want to. We have to make those choices, or the government has to make those choices because it's their call.
Thank you very much, Anthony. I'm going to bring this to a close now as we're somewhat over time. We are getting questions on how we can affect change towards the right kind of strategy. I think everyone agrees we can do so without recrimination and with accepting that we've learned about how to manage this, that the world is changing with new variants. But I suppose there are a lot of people who are wondering, where is the leadership lying and how do we influence government to make the decision to go all of the way for what needs to be done? And so I'd like to invite Tony to make any final comments that he'd like to on this before we close.
Well, thanks for the easy question. I think that unfortunately it's a case of simply plugging away at it. These types of seminars, the continual pumping out of accurate new evidence of the type that we've seen today, getting that to the widest audience possible, and ensuring that public opinion is influenced by this knowledge will give, I think, politicians the courage that they need to make the right decisions. But we're also seeing, you know, that they are showing that the capacity to learn. Some of the more recent decisions reflect a change in approach to what we've seen before. So I think it's just a question of keeping on, not so much the pressure as providing the evidence that they need to ground those decisions. And obviously NEFIT is doing a very good job, but it is circumscribed by the fact that its advice is to government. Government will decide. Groups like ISAG and others can bring the information to much wider public debate and therefore influence the environment in which the government makes those decisions and the environment in which it receives and considers NEFIT's advice. So I would say just keep going, keep plugging away.
Thank you very much, Tony. It's clear we do like to talk very much in Ireland, and a lot of the conversation has been influenced by many individuals in the media from all angles, and it has been observed through some of the questions that how we interpret the media can sometimes give a different impression of what public opinion is. We know today from polling that the majority of the population are in favor of an elimination strategy. You could argue this was the case before Christmas, that we didn't have the direct information. Post-Christmas, it's very clear that this is currently what the opinion of most people are. So I think sometimes when we hear arguments, polemical arguments often about opening up the economy, though they can be made in good faith and that they can still be made as a reasonable argument, perhaps an argument that doesn't have much evidence in favor of it, but as a genuine perspective. It currently only represents around 10% of the population, and the majority of the population want to take a much more conservative approach, and I think over 50% explicitly one that aims towards elimination of COVID-19 from the island of Ireland. I'm going to bring proceedings to a close now, and I'd like to thank all of our attendees, all of the panelists, and particularly our 4 speakers for making the effort to present such important presentations, all very understated, but I can't overemphasize the gravity, I think, of everything that has been said in all 4 presentations today. The first one emphasized the current situation that we're in Ireland and how we need to pay extra attention to what we're doing in Dublin. This very much affects how we manage school reopening and how we plan school reopening. The middle 2 presentations provided very clear facts and shined a light on very essential known knowns about how the pandemic has played out in Ireland in a way that we didn't understand even a few weeks ago. And the final presentation, I thought, provided an extremely sagey and experienced perspective on what needs to be done from someone who knows very well what the capacities are for the health service in Ireland to implement. So thank you all for coming, and we'll be continuing with these webinars on a weekly basis.